Okay, so good morning, everyone. I'm Brianna Yoakum. I'm the Professional Development Coordinator as well as the Accreditation Coordinator for WAQRR. Sorry, I was had to enable something. Yeah, so I'm joined here by Jason Bliss, who is our Executive Director. He's kind of going to be behind the scenes today. I'm also joined here by Garrett, Kostin, and Milena Stott, who is our presenters today. So thank you so much for joining us for our conversation around trauma-informed care. So I'll be helping with the event today by monitoring the chat for questions, and you guys are encouraged. It did show that we're going to have a bigger group today, so you are definitely encouraged to put all your questions in the chat, and if we have time at the end, I'm sure Garrett will even leave more questions. Garrett and Milena will leave more questions open for the chat. I'm also going to have this recorded and make the slides available for everyone who attended today. And so now I'd like to introduce our presenters today. So we have Milena Stott, who is a LICSW and a SUDP, and she started her social work career working with children and families as a clinician. She's gained experience in various settings across the continuum of care with children and adults. So no matter the setting, trauma and adverse childhood experiences were a common theme in the lives of people. As a clinician, she's helped her clients find the support and interventions to heal. And as a supervisor, she's helped others understand how to work with persons who have experienced trauma. Today, Milena provides training and technical assistance and also does outreach and engagement with the Fletcher Group to promote quality and capacity for recovery housing and recovery support. Garrett Kostin, he's a LICSW and a SUDPT, and after gaining several years of valuable experience in both inpatient and outpatient behavioral health and medical settings as a social worker and clinician, Garrett now works as a behavioral health consultant. He facilitates workshops and trainings on person-centered and trauma-informed care, motivational interviewing skills, medication-assisted recovery, and many other topics. He is energized by transformative, person-centered approaches that aim to reduce disparities and inequities in healthcare and society. So we are so glad that Garrett and Milena get to put this presentation on for us again, as trauma-informed care is such a huge aspect of better caring for individuals in recovery. So I will now pass it on to Garrett and Milena.
All right, good morning, everyone. It's so nice to see your faces, or at least your names in little black boxes. We got the opportunity to do an earlier version of this webinar about a year ago, and I think we only had 3 or 4 participants. So this is wonderful to see so many folks today. I'm going to go ahead and share the first slide. Looks like does that look good, Brianna?
It needs to be full screen. So perhaps the other one.
There we go.
Perfect.
All right, and I'll turn it over to Milena.
All right. Thank you all for being here today. And I'm here to kick off our discussion around trauma-informed care and how it relates to your work in recovery residences. Garrett and I have had the pleasure of working together for many years, and we've mutually served many folks through recovery settings. So really happy to engage in this discussion with you all today. I'm going to just kick us off here, and then Garrett's going to do some overview of what to expect today, and then we'll dive into the content. Next slide, please, Garrett. So why are we talking about trauma today? We know that exposure to trauma has a relationship to the development of substance use disorders, and we'll look at some data and why that is throughout the course of the presentation. We also know that approximately 2/3 of individuals that come into care report some level of childhood abuse or neglect. We know that half of women in substance use treatment have reported a history of sexual trauma, and that about 20% of the population of women in the general population have also experienced that. There was also a study of male veterans in substance use treatment, and that study found that 77% of those in treatment were exposed to severe childhood trauma, and about 58% had a history of lifetime PTSD. And so whether you know these statistics or not, we've presented some compelling ones to you to understand the nature of the prevalence of how many people are coming into our care that experience some of these challenges. Next slide, please.
All right, so we'd like to share some foundational principles to make sure we're all on the same footing before we get into the heart of this presentation. So this is really the foundation that Milena and I are basing our presentation on today. We know that the results of trauma are most frequently disempowerment and disconnection from other people, and that recovery from trauma, similar to recovery from substance use disorder, is based upon the re-empowerment of the survivor and the creation of new connections. That the recovery really needs to take place within relationships. It cannot occur in isolation. And so while recovery residences are not treatment sites, they do have the unique and powerful opportunity to provide safe, supportive, and validating context for the formation of healing relationships that foster new experiences of acceptance and belonging for trauma survivors. And that also, as you all know, contribute to better outcomes for folks in substance use recovery. And so we stand by the fact that recovery residences can aspire to serve as bridges to new community, as places that help survivors not only reform connections with people, but also reconnect with society and increase the likelihood of their sustained SUD recovery. So sort of a guiding principle that you'll hear us touch on throughout this morning is that trauma equals disempowerment and disconnection, and therefore healing of trauma requires empowerment and reconnection. And a lot of that is what trauma-informed care aims to support and foster. So the way that we, or the objectives for this morning, this is what we hope that you gain and are able to take away with you by the time we're done with this webinar this morning. You should be able to have a solid understanding of the definitions of trauma, traumatic stress, toxic stress, as well as PTSD, complex PTSD, and adverse childhood experiences. Also, we hope that by the end, you'll understand the correlation between exposure to trauma and substance use, as well as the role of traumatic symptoms in SUD recovery, how those symptoms can complicate recovery for folks. Also, we're going to spend a lot of time exploring the principles and strategies of trauma-informed care. And by the end, we hope that you'll come away with an understanding of the value of applying trauma-informed approaches in recovery residences, including your own. And finally, we aim to have you leave with some practical tips and suggestions for making your recovery residence more trauma-informed. And so here's a quick overview of just the layout for this morning. Milena is going to take the first section, defining trauma, PTSD, and complex PTSD, also going into more detail about adverse childhood experiences and traumatic stress, along with their prevalence and how it correlates with substance use later on in life. We'll have a sort of a couple minutes for a check-in in the middle, where we'll have a chance to respond to any questions that have come into the chat box. Feel free to put questions or comments in the chat box throughout the presentation, and Brianna will be monitoring that. After the check-in, we'll get into the meat of the trauma-informed care section of the webinar, where we'll define and review some of the core principles, and then talk about the role of trauma-informed culture or care in recovery residences specifically, and finally end with the practical section, some effective approaches, tips, and suggestions for fostering trauma-informed recovery residences. And at the end, we'll have another couple minutes for questions and discussion. So I'll turn it back over to Milena.
Thank you, Garrett. So to ground us today, I'm going to start us off with some definitions around trauma. And when I think about trauma, I think of the absence of safety, right? It's an experience often that somebody encounters that's beyond the realm of normal or expected. And actually, to that point, right, there are also experiences that people normalize and expect as a result of their environments because they become desensitized to those. So when we think about beyond the realm of normal, that's the collective experience of normal. And that trauma also involves an actual threat or death or injury to oneself or others. So it can actually be the act or the threat of the act that is traumatic. And that trauma causes intense fear and horror, and also has both a physical and emotional response. So some of the physical responses can include feeling tense or feeling sick to your stomach. People often respond, or having a heart palpitation or tremors. And that those experiences overwhelm the person's ability to cope, so that the trauma hijacks their brain and their physical and emotional self and creates this sense of cloudiness in one's ability to cope, sometimes for a short amount of time and other times for longer. So trauma is sometimes sudden and unexpected, and that the person perceives it as dangerous or life-threatening. And that piece about perception is important, right? Because we all have different levels of perceived threat. And so that's important to consider as well, that experience can vary from person to person. But the common element is that it's perceived as dangerous or life-threatening. And that it overwhelms the person's ability to function. So when you get triggered by trauma, you find yourself shutting down and being unable to manage your day-to-day self because your emotions are challenged and destabilized. And trauma is also person-specific, right? That goes back to that piece around perception, is that people can experience the same situation but have different responses to it. And the reason for that is because we like to call it risk factors and protective factors, right? That part of what we do in our work is try to provide people with the skills or the protective factors, like the environment, the support that help them overcome trauma. So we know that people that have supports and protection in their environments have lower responses to trauma because those things are in place as balancing factors. And so that experience is very real and based on one's experience and history, as well as one's environment and the amount of support that they have in that environment. And so a lot of the work that we do in recovery housing and treatment is to provide that environment that aids those protective factors to reduce the level of response to trauma. So what are some examples of traumatic experiences? So the line here that you see is really to help you understand that the proximity of the trauma to the person creates an enhanced experience. So natural disasters are a little more far removed, right? And the experience is a community experience. And so people can have traumatic responses to natural disasters as well. And that includes, examples here are earthquakes, fires, flood. In natural disasters, people can sometimes lose their housing, and that's a traumatic experience for folks. They can also be hurt or experience the grief and loss of somebody else being hurt. And that's can lead to a traumatic response as well. Community or national events or circumstances can also create trauma. So for example, acts of terrorism or war, we know that there are refugees that, come into our community who have experienced trauma as a result of terrorism or war. But there's also other forms of trauma that are less crisis oriented, and those are repetitive societal discrimination or oppression or historical trauma. Those live with families, and families pass those traumas on as well through the way that they engage. Family circumstances can also be traumatic. And we'll talk about that in the case of ACEs a little bit later, but we know that abuse, neglect, poverty, domestic violence, death of family members, witnessing certain acts can also create trauma. And then lastly, there's the personal trauma, right? That's front and center on the individual and typically creates the most challenge for folks. And examples of this include physical or sexual abuse, emotional or psychological abuse, imprisonment, life-threatening accidents, injuries, repeated abandonment, sudden loss. All of those things can create a traumatic response in somebody. So what's the difference between traumatic stress and toxic stress? And the best way to think of this is the idea of duration, right? So how long does the stress last? Traumatic stress is when the body and mind respond to an event in an adverse way. The person becomes shocked or in some cases numb, and that results in increased fear and anxiety. When traumatic stress is left untreated, it can lead to a diagnosis of post-traumatic stress disorder. There's also acute stress disorder, which can be resolved with immediate services and treatment. There's an example of that is called critical incident debriefing, that oftentimes when you help the person process the trauma, it can have positive effects and preventing the traumatic response from growing. Some common things that people report when they experience traumatic stress include intrusive memories or inability to control their emotions, nightmares, or flashbacks. Some folks also report feeling tense or depressed. With toxic stress, that happens over prolonged amount of time, or it can be the frequency of the events as well. And so toxic stress over time can actually cause severe impairment with some physical, emotional, and social functioning impacts. And we'll talk about that when we talk about ACEs. Next slide, please. So what is post-traumatic stress disorder? So post-traumatic stress disorder happens when, following a traumatic response for more than a month, the person experiences significant symptoms. And PTSD has been studied for a long time, and the people who studied it have created a list of symptoms that happen as predictable responses to abnormal experiences. And these responses basically is the way that our brain tries to protect us psychologically to help us make sense of what happened and help us avoid the future situations that may result in more trauma. So if a person's symptom lasts for longer than a month, as a result of a trauma, you're looking at the need to potentially send somebody to an assessment to diagnose post-traumatic stress disorder. Next slide, please. So how can you tell, what are some of the red flags? If you think about recovery housing or your setting and you think somebody may be struggling, you think that they may have experienced a trauma, or you may know that they've experienced a trauma because they've shared that with you. What are some things that you might observe? One thing that you might observe is that they might feel overreactive, to something. People often report that if they hear a loud noise, right? So war refugees, for example, when they hear fireworks, they associate that with a bomb that they may have heard in war. And that triggers their brain to sometimes feel panicked. The physical reaction may be their heart racing. They may experience irritability or anger because that's the response of the discomfort to the situation. You may see them shaking or hyperventilating. They may report, a rapid heart rate or feeling dizzy. And those are sort of the symptoms of arousal. People can also experience depression as a result of trauma. They may not enjoy things that they used to enjoy. They may choose to isolate themselves. And we know that isolation can lead to substance use, right? They may not feel as motivated to pursue things because there's this learned hopelessness or worthlessness that they feel because they feel stuck. They feel like they want to move forward, but they can't move forward. They may also experience thoughts of suicide or self-harm. Then you also have intrusion. So in some ways, their triggers can lead to uncontrollable distressing thoughts or memories. So something might remind them of the trauma, and they may not be able to stop thinking about it. And that can carry over into nighttime, where through nightmares they're thinking about it. It can also be flashbacks. They can be walking down the street and see something that reminds them of the traumatic event and think about the traumatic event. And there might also be some unpredictable sensory triggers, right? Somebody might touch you on the shoulder, and that might be associated with a negative experience. And so that triggers the individual. And then people also go to great lengths to avoid feeling that way, right? We don't like to feel uncomfortable. And avoidance can result in extreme efforts to stop thinking about the trauma. And many folks who use substances report that they use substances as a means to cope, right? And so when we think about stopping use of substances, we have to replace that as a coping strategy with something else. And so the other thing that we also see is that people may avoid people, places, or things that remind them of the trauma because it feels so uncomfortable, right? This idea that you will go to any length to avoid feeling or experiencing the threat of feeling those things. Next slide, please. So when we think about trauma and PTSD, which symptoms are risk factors for developing a substance use disorder? This is us inviting you to think about the relationship between trauma and substance use. And please feel free to chat into the chat box your thoughts on which symptoms are risk factors for developing a substance use. And if anybody wants to share as well, that is okay too. And maybe also be arousal. Great, Oliver, thank you. Depression, all of them. You guys are getting it. Absolutely. Isolation, all of those things are risk factors for developing a substance use disorders. And then why would using substances be attractive to somebody using or experiencing those symptoms? I think wanting to avoid problem is a huge risk factor. Yeah, and you know what? One of the treatments is exposure, right? So when we think about treatments around trauma, a lot of that work is working with people to actually try to experience and get used to experiencing and coping with those things, self-medicating, numbing the feelings. Yeah, so absolutely, substance use that's exactly why people report using substances. It helps them escape. In some cases, they say it helps make them feel safe in certain environments, right? Because some substances have a tendency to create that experience for folks. A combination of all the groups, drug and alcohol works for instant numbing and avoidance. Yep, you guys got it. You understand the relationship.
Yeah, this discussion is bringing to mind the saying that trauma is the real gateway drug. You might have heard that expression. It seems somewhat counterintuitive because trauma is not a drug, but what we're learning about is that there is such a high correlation between exposure to trauma and later substance use for all of these reasons that you all are noting, that substances are, at least initially, an effective way of managing or numbing the symptoms of trauma.
Yeah, and it's really important to understand that, right? Because it helps us build empathy for the challenges that people experience in their lives, right? So I see the comment here, it's an effective way of relieving and distracting from painful and debilitating symptoms of trauma. And that is 100% right. If we start to blame individuals for their use of substances rather than understand why they're using substances, we lose the opportunity for empathy and connection. And we know that connection is a part of healing. And when we isolate people, we can also create further challenges for them, because now we've perpetuated that trauma experience, right? So creating a level of baseline understanding and safety in the setting can be really important for engagement and retention as people come into our care. All right, thank you for that, everybody. So when we think about post-traumatic stress disorder and the impact of trauma, right, it affects our beliefs. When we think about our trauma, it affects what people consider safe. It affects their ability to trust others and develop trusting relationships, which we know are really key to recovery. It can impact somebody's self-esteem. Sometimes people blame themselves for the trauma or feel that they're unworthy as a result of the trauma. And then it can also change our identity. You know, sometimes people who experience trauma feel like they deserve it and it's because of who they are. It can also affect their worldview, right? This is the way the world works. And so I'm going to interact with the world in a certain way, or even their spirituality. They may lose connection with spirituality because they're looking so badly for safety that they can't find it. It also challenges people's ability to manage their feelings and connect with others. And we know that emotions and social connections are important to recovery. It affects our body and our brain. Survivors often talk about always feeling in danger. And so they're always waiting for that next dangerous thing to happen. We call that like catastrophic thinking, right? It's like, I've had these experiences over and over again. Why should I expect differently? And so then in order to protect myself, I'm going to change the way that I interact with the world to avoid all of those things. You know, people sometimes report too that their memory and perception are challenged by trauma. They can't think straight because their brain is flooded by some of those emotions and the stress that is associated with their emotions. And that can lead to changes in their judgment and how they're able to weigh consequences, right? Because it's really about finding the relief rather than thinking through the process. And so when we do our work, a lot of that is about helping people retrain the way that those pathways happen. All right, next slide. So just a little note about complex PTSD. It's not recognized commonly in the DSM, which is the Diagnostic and Statistical Manual for Diagnosing Trauma, but it is recognized by the World Health Organization as a diagnosis. And in addition to the symptoms of post-traumatic stress disorder, people with complex PTSD, basically, they also experience disturbances of self-organization. And that they can't regulate themselves emotionally. They have challenges interacting with other people. and they have this negative self-concept. So they've really internalized the trauma in the way that they behave, and in the way that they think, and in the way that they feel. Okay.
All right, give me a second to get back. We have a video, a short video, explaining a little bit more about complex PTSD and looking at the distinctions between PTSD and CPTSD. This is a video from the BetterHelp platform, which does not imply an endorsement of their services, but the information is provided by a psychologist, Dr. Sonia Bruner. And we're just going to watch about the first 4 minutes. Oops. There we go.
Many people have heard of PTSD or post-traumatic stress disorder and are at least somewhat familiar with what that might look like when somebody comes home from war, or goes through a really horrific event like that's potentially life-threatening. What I think many people are not aware of is a separate category of PTSD, which is called complex PTSD. And I want to explore that a little bit in today's video. This is something that I feel really strongly about. I've done a lot of work with people with this diagnosis, and it's tough to see the pain that they're in when they present for treatment. And so I'm going to spend a little bit of time talking about symptoms and what that might look like, but more importantly, I'm going to speak to the experience of sitting with somebody who is going through this, and what it really might present as in the room or when you're in front of somebody. What is the difference between post-traumatic stress disorder and complex post-traumatic stress disorder? I think this is such a great question, and something that there's a lot of confusion and even just not awareness around. And so the main difference between the two is that often PTSD is one distinct event, or maybe a series of events over a small time. So you're serving in Iraq and you're in this war zone and you see some really horrible things, and you come back and then you're diagnosed with PTSD. And that has a certain look and a flavor to it. With complex PTSD, this is a person who over years has experienced several traumatic incidences where they feared for their own safety or the safety of someone they loved. And so, as opposed to one discrete event, this is a series of events over, years that gradually accumulate to the point where the individual will present with symptoms of PTSD. And these symptoms are often more severe in some ways, and we're going to talk a little bit about that next. One of the most difficult things about complex PTSD is that the trauma that people go through is typically of an interpersonal nature. And so this is things like, abuse from a parent, or sexual abuse. And so, but this occurs over and over and over again, to the point where the individual really loses a sense of safety and trust in others. And so much so that we're now understanding that there's a huge connection between adult physical health issues and some of the mental health problems that come from being raised in an unsafe environment. And unsafe doesn't have to be physically unsafe. It can be psychologically unsafe. It can be emotionally unsafe. And so we're going to talk a little bit in the next segment about something called the ACEs, which is the Adverse Childhood Events Questionnaire.
All right. And that leads right into Milena's next topic.
Thank you, Garrett. As we heard in the video, that the prolonged and continued traumatic events are what lead to complex PTSD. And so in that regard, it's important to talk about the ACEs, adverse childhood experiences, which are basically a set of stressful traumatic events that occurred during childhood and can have enduring negative developmental, social, behavioral, and physical effects. And I will say this, in all of my work, I worked in a lot of substance use treatment settings. I've done a lot of assessments. In our assessments, we ask pretty personal questions about people's histories that help us understand and diagnose them. There is an effort now to think about assessments and what we're asking in assessments to make sure that they're minimally invasive and provide us only with the necessary information that we need to support somebody, knowing that when you ask some of these questions, it can bring back the trauma and the traumatic experience for the person, and without the appropriate supports can help them or can make them further traumatized or lead them to engage in the behaviors that maybe they've adopted for coping, as Chris actually has said in the box in the chat feature. And so the ACEs study was a longitudinal study that looked at 17,000 adults and basically looked at their medical records and was trying to understand, what is the connection between trauma and later health outcomes in adults? How do we see, how do we assign a score to the number of traumatic events or experiences that a person has had? And how does that score relate to some of the conditions that we find that they're experiencing later in life? This research study was conducted by the Centers for Disease Control and Kaiser Permanente across 25 states. So we have a pretty large sample size in the standard questionnaire that really helps us kind of study, what's the relationship between the number of trauma events and the other health conditions. And so we'll look at what the study found. So it helped us answer the questions of, why do people react to trauma differently? And that was that idea of the risk factors and protective factors. And why do some people develop PTSD and others don't? And then what are the impacts that early life adversities have on our behavioral choices and our health outcomes later in life? And basically, what they found is that ACEs are basically potentially traumatic events that, can lead to those health challenges later in life. And some examples of ACEs, or adverse childhood experiences, can include physical, emotional, or sexual abuse. Extreme neglect also falls under that category. Witnessing domestic violence. We also know that sometimes witnessing domestic violence can lead to trauma, or it can lead to one adopting beliefs that, this is a normal way to interact with folks. And so they carry that on into their future life. Parental substance abuse can be a traumatic experience because of the nature that substance use has on the parents and their ability to parent and interact within the family unit, how they might act when they're under the use of substances. Mental illness within a family member as well, similar to substance use, how those symptoms and behaviors play out within the family unit impact the development of the child. Suicide or death in the family, especially witnessing a traumatic death or, the suicide of a close family member, or, being isolated from a family member because of crime or imprisonment. And all of these things, can lead to later health consequences. So what are the questions that are being asked in the adverse childhood experience questionnaires? It's a pretty simple questionnaire. There's 10 questions, and you basically get a point for every time you say yes within the questionnaire. And the questionnaire is basically asking about those elements that I referenced in the other page. Did you experience emotional, physical, or sexual abuse, emotional or physical neglect? Was there, separation or divorce of the parents? And in the case of separation and divorce, right, if there's domestic violence, that adds another layer of complexity. There's also financial control in some cases, or deprivation in others. Did you witness your mother being treated violently? Is also a question. And then it asks about, who was living in the home, and of those people living in the home, did they have problematic substance use, or was there chronic depression or mental illness? Was the person institutionalized or suicidal? And then the piece around incarceration. Generally 60% of us have experienced at least one of these things. That's what the study found in their sample before the age of 18. But there's also 17% of folks who experienced 4 or more of those things. And then they looked at, what were the differences between the people who only experienced 1 versus the people who experienced 4 or more, and what did their lives look like later? And so basically, this is what they found their lives look like later, is that ACEs, or adverse childhood experiences, they have an impact on health outcomes, well-being, and quality of life. And that the scores, a higher score is correlated with somebody smoking or having challenges with obesity, alcoholism, risky sexual behavior, and injection drug use. ACEs scores are also predictors of future depression and suicide. So the higher the score, the more likely you are to later experience challenges with that. And that, higher likelihood of PTSD symptoms and diagnosis was also found in people who had higher ACEs scores. It also had an impact on your physical health. We know that people with higher ACEs scores are more likely to experience heart disease, lung disease, have HIV or other sexually transmitted diseases, or experience obesity, mainly because of those risk factors, right? They influence your behavior, and your behavior influences the development of some of these conditions. And of the 10 most common illnesses in the US, addiction has the second highest correlation with adverse childhood experiences, and that COPD, which is a heart condition, is number 1. So you see that trauma is affecting both the heart and our substance use, with the heart impact being associated with high cortisol levels, or the stress hormone that you experience. And then also, some of the other behaviors that you may engage in, such as smoking or eating, to alleviate some of the stress and the challenges related to stress. They also found that participants with 1 ACE, with a score of 1, were twice as likely to have made a suicide attempt as those with none. And that participants with an ACE score of 4 or higher were 12 times more likely. So again, you see that the more adverse childhood experiences, the higher your risk is. They also found for those that had a score of 4 or higher, they were more likely to smoke, right? They were 7 times more likely to use alcohol or substances, and 4 times as likely to have emphysema or COPD, which is a consequence of the smoking. An ACEs score of 6 or higher had a 500% greater rate of alcoholism and over 4,000% greater use of IV drugs. So as you can see, there's a strong correlation here between the experiences of childhood and our health and social behaviors later in life.
Mm-hmm. So at this point, we'll take a little break and let everyone else have a chance to share some responses or reflections to the information that Milena has shared, or some thoughts about what all of this, everything about trauma that we've reviewed, what does it mean for our work with supporting those in SUD recovery? Something that really came up for me as Milena was reviewing adverse childhood experiences was that what happens in childhood doesn't just stay in childhood. And sometimes that's really unfortunate, but these experiences that children can be exposed to before their brains are fully formed, before they have opportunities to venture out into the world and discover who they are, it really deeply impacts them, lifelong impacts. I see a couple of chats coming in. Thank you for those.
I'll go ahead and read them. So
Thanks.
Jefferson says, this is my third trauma-informed care training. It never gets old, and it's always relevant and applicable to any human relationship we have. Thank you so much. And then Chris says, is there an assessment that helps to identify strengths and other protective factors?
Yeah, I'll respond to the first one, and hopefully Milena can take the second question about an assessment. I absolutely agree that we're talking about the topic of trauma-informed care. I think that we might do better to conceive it as trauma-informed ways of interacting with people in the world. And that's certainly closer to what it looks like in recovery residences. These are just, it's trauma-informed culture. It's using this knowledge and insight that we have about trauma and the effects and how people cope with the effects that really can affect the way that we perceive other people and their behavior and their choices, and it hopefully can have an effect on the culture, the way that we interact and support people generally. And Milena, what do you think about the question about an assessment that can help identify risks and protective factors?
Yeah, I am actually going to post some resources into the chat based on that question. But basically it's almost like a checklist, right? And it's almost like a training in and of itself to understand what the risk factors and protective factors are. SAMHSA has some guidance on there, and I can definitely put those resources into the chat. One of the things, that the Prepare tool does, which is a social determinants of health screening tool, it attempts to assign a score around social determinants of health, and it recognizes some of the trauma elements as contributing to that. So that is one screening tool. And then I will also post the other resources in the chat.
We have a couple other comments here. Carol says, interestingly, two children can come from the same environment and react differently, becoming a product of that environment or something quite the opposite. Jackie says, I have to continually be aware and honest with myself. I love to learn on this topic, but it can also trigger my own trauma and lived experiences. It makes me a great peer as long as I do the self-care.
Yeah, was that Jackie you said, Brianna?
Yeah.
That last comment? Yeah, thank you, Jackie, for bringing that up. I've noticed in myself, preparing for this webinar over the past week and refreshing my knowledge, it's affected me too. And so thank you for sharing with us, and it creates a great opportunity to encourage everyone to think about how this information affects you and how you're going to take care of yourself after we're done this afternoon. I'm heading to the gym. It's also pretty good weather where I am in Olympia. I hope some folks can find ways that help them feel grounded after engaging with this what can be difficult information.
And then Henry said, giving people grace and remembering what trauma does and how they can heal. Yeah.
Yes, yeah. Thank you very much for that, Henry. I'm trying to find, I have a couple slides just because it seems like folks are interested in a little bit more about risk and protective factors. So this is a slide from an earlier version of this webinar that I actually decided not to include because I didn't know where this chart came from, and so I wasn't able to give credit. But here we see some of the risk factors, things that increase folks' vulnerability for being affected more strongly by traumatic exposure. And so they're in categories of biophysical risks, psychological risks, social, and spiritual. So we can see a lot of the similar categories for ACEs are in these risk factors: abuse and neglect, domestic violence, unhealthy relationships. Things like traumatic brain injury or chronic medical conditions, poor nutrition, all of those things can increase our vulnerability to being impacted severely by traumatic situations. And then conversely, the protective factors, things that help folks build up a store of resilience so that when trauma occurs, when we're exposed to it, we are able to pull ourselves back up, pick up the pieces, and figure out how to carry on. And those are things like starting from just having housing, shelter, and our essential needs met, to having had reliable support as a youth, having a store of coping skills that help us regulate our emotions and our activations. Already, going through life with having positive self-regard, self-esteem, and confidence about ourselves. So that's some of what we're talking about when we talk about risk and protective factors. And really glad that Milena is going to be able to drop some resources in the chat box also.
Yeah, there's quite a few in there at this point. So with the last one being focused on child welfare, that has a nice cluster of categories.
Mm-hmm. Excellent. Okay, any important questions or comments that anybody would like to get in before we move on to part 2 of the webinar?
Florence said, one thing I'm apprehensive about with ACEs is that 75% of the study was done with the Caucasian population, less than 5% was done with the Black population. And he says, so we're eliminating a huge percentage of the BIPOC and intergenerational trauma. Sorry.
Yes, that's a very valid point. And we know that some of that, when we look at our statistics around health disparities, some of that data shines the light on the relationship too around those risk factors, protective factors, and what it means to be a person who also experiences oppression and discrimination in addition to some of the other social factors. It definitely enhances and compounds the experience.
Yes, and I agree. That's a very valid critique of the original ACEs study. Fortunately, additional ACEs data is continuing to be collected every day. They're not in Washington State, but there are a few states where the ACEs questionnaire has been built into the standardized assessment or intake paperwork at various healthcare entities. So the researchers are continuing to get more data, and hopefully it is much more varied and representative of the demographics in the US. Yeah, and I also saw a comment, I think it was from Maggie. She mentioned the book, The Body Keeps the Score by Bessel van der Kolk, as being a book that's really helpful with coping strategies and also helping her as a peer know how to better support clients with PTSD and CPTSD. Yes, there is a slide at the very end where I listed some recommended books and websites about trauma, and that book, The Body Keeps the Score, is on the list. So I'm glad that sounds like at least one person's read it and agrees that it's a good resource. All right, let's get back into the slides. Thank you all for your participation and interaction. So just to sort of get us centered and grounded before we dive into everything about trauma-informed care, just as sort of a perspective cleanser, I want to mention that the good news is that despite the horrific experiences that can result in traumatic stress responses, recovery from trauma is possible, and it happens every day. And we're continuing to learn more about how to make the recovery more effective and support folks in recovery. The bad news is the reality check is that the path to trauma recovery is long and challenging. It's very difficult to predict how long successful recovery might take, especially when it's complicated by issues of substance use disorder. And at the same time, the good news is that we now have effective tools to support folks in trauma recovery that can be applied or adapted for many different contexts and levels of interaction, not just the therapist couch and not only strict treatment facilities. So what that looks like, or one of the primary tools that we're going to be learning more about now, is trauma-informed care. And as we discussed a couple minutes ago, if it's helpful for you to think about this in terms of just trauma-informed culture or trauma-informed ways of interacting with others, so be it. So be it. But I use the term trauma-informed care in the abbreviation TIC in these slides. So TIC is an approach originating in the human services and clinical fields that assumes that an individual is likely to have a history of trauma. And so we can think about it in terms of applying universal precautions. We know that the vast majority of folks in treatment for behavioral health issues and just a large percentage of folks in the general population have had exposure to traumatic experiences. So we take precautions and apply sensitivities and our knowledge and help us generate compassion for everyone universally, because we don't know exactly what someone has had in their past or how it's contributing to their present day presentation and behavior. So trauma-informed care understands, has compassion for, and seeks to redress the pervasive and detrimental nature of trauma and post-traumatic symptoms, including how they affect people's outlook and behavior. That the fact that trauma-informed care seeks to redress the devastating effects of trauma is really the justice part here. It's saying we recognize that that traumatic experiences aren't the fault of the individual. It's really not up to any one individual how much trauma they are exposed to or what their reaction to it is. Therefore, if somebody has been severely impacted, they deserve compassion and deserve the validation. So trauma-informed care and just trauma-informed ways of interacting with others in general promote environments of dignity and healing rather than practices that may inadvertently isolate someone, trigger a negative response, cause them more difficulty, or frustrate one's recovery from trauma. And here's a pretty good quote from Elizabeth Hopper at the Trauma Center. She describes trauma-informed care as a strengths-based framework that is grounded in an understanding of and responsiveness to the impact of trauma, that emphasizes physical, psychological, and emotional safety for both providers and survivors, and that creates opportunities for survivors to rebuild a sense of control and empowerment. Remember, I mentioned at the beginning that the effects of trauma are disconnection and disempowerment. And so therefore, with trauma-informed care, we're seeking to create space and create opportunities for folks to relearn senses of control, trust, empowerment, and connection. So here's a caveat, a little warning before we get too far into trauma-informed care. I want to be really clear that trauma-informed care is not treatment for trauma. It's quite distinct. And here's a quote from from a book called Trauma-Informed Care for Substance Abuse Counseling that makes it really clear. Trauma-informed approaches are not designed for the treatment of the trauma experience, such as processing of the trauma narrative, but rather for assistance in managing symptoms and reducing the likelihood of re-traumatization of the individual during the recovery process. So this might be relieving for folks to hear who feel like, well, I'm an SUD person. I don't know about trauma. I'm not on the mental health side. I that's not my ballpark. I don't have any reason to go there or be involved with it. That's okay. Trauma-informed care doesn't require you to be on the mental health side. It simply requires you to seek to want to support folks who have gone through trauma. And for folks who feel like, well, I want to support folks in recovery, and I recognize that a lot of them, their recovery is impacted by trauma, but I think it probably takes a long time to learn how to provide effective treatment for someone or proper counseling. That's not what trauma-informed care is either. Actually, the detailed traumatic disclosure, or inviting someone to tell you about their trauma, to sort of unpack their trauma case, is really discouraged, especially by those who are not formally trained in trauma therapy. There's sort of a standard message or lesson of, don't uncork what you can't contain. Don't invite someone to open a Pandora's box of trauma if you're not confident that you have the skills and the training to help that person repack at the end of the conversation, so that they don't leave the conversation feeling discombobulated or activated or in distress. So that being said, recovery residents, operators, and staff are encouraged to consider themselves and aspire to be a bridge to clinical trauma treatment, and for folks who are continuing to be impacted and bothered by symptoms of traumatic stress. And the way that you can best do that is by increasing your own trauma awareness, which builds up your own knowledge and compassion for folks who have survived traumatic exposure. And joining this webinar today, some of you, this is your third time learning about trauma-informed care. All of that increases your trauma awareness and your ability to act as a support and a bridge for recovery residents from your recovery residents to trauma treatment. Once somebody is ready to engage in specialized treatment, it is quite possible that without the trauma-informed culture that you're able to provide, that you're able to bring to your setting at the recovery residence, someone may not ever get to the stage where they're ready to engage in specialized treatment, and that means that they're going to be continued to have their functioning negatively affected by the symptoms for longer. All right, so why trauma-informed care or trauma-informed culture? Why is this pretty important? Well, we know that when the signs of trauma are misunderstood or ignored, or not noticed, or not noticed for what they are, what this can cause for a resident or for someone in SUD recovery is that it interferes with their support-seeking behavior when their symptoms aren't validated and recognized accurately. It can also limit folks' engagement in services and their likelihood of healthy reconnections with the community. It can make abstinence and engagement with sober support more difficult for folks. It can also unintentionally isolate someone from supportive recovery communities. What a tragedy that would be if somebody is coming to you with co-occurring diagnoses of substance use and trauma-related stress, and because of misunderstanding about the effects of trauma, that someone perceives that the recovery community is not safe or welcoming for them, and they're pushed further out of the recovery community. That's something we really want to avoid. Also, when we are not trauma-informed, we have a higher potential of inadvertently re-traumatizing folks we are trying to help, causing more disempowerment, compounding the disconnection that somebody's already experiencing. So what does being trauma-informed mean for our work in the SUD recovery community? It means that we work to establish supportive, empathetic relationships with people who have likely been hurt, betrayed, or taken advantage of by those who are supposed to be counted on for safety and protection. We actively seek to foster trust and respect for other people's autonomy and dignity. That's the bottom line for trauma-informed care. And so let's look at the 5 core principles of trauma-informed care. As you can see here, there's safety, trustworthiness, voice and choice, collaboration, and empowerment. So safety is all about understanding that somebody who is struggling with the effects of traumatic exposure has likely had their sense of personal, physical, and psychological safety shook to the core. And so that taking steps to ensure their physical and emotional safety in the recovery residence in this context is incredibly important. Also, supporting the stability and predictability of an environment, of a routine, helps folks rebuild a sense of safety, and basically taking steps to do no harm, to do what we can to avoid triggering and re-traumatizing folks. Trustworthiness is about showing that possibly unlike other caretakers or folks who have provided some of your needs for you in the past, who may not have turned out to be trustworthy, we will demonstrate consistency and follow through to foster trust, to show that trust is something that can be afforded to others, and it's not something that you're never going to be able to have again. And the way that we can do this is by making expectations clear and setting and modeling appropriate boundaries, and taking our responsibilities seriously, so that folks can learn that we're good for our word. Voice and choice is one of the core principles, because trauma is something that takes away, that really steals someone's choice, and also that they have no voice in. So with trauma-informed care, we encourage the empowerment and autonomy of folks by prioritizing their choice and their control over different aspects of their recovery. And collaboration is in line with that. It's looking for opportunities, or creating opportunities for collaboration and the sharing of power, sharing power and sharing decision making. This reinforces folks' self-esteem, their sense of self-efficacy, and the worth and the potential that they bring to the interaction. And finally, empowerment, which is about treating folks, reinforcing that they are able to manage a lot of things on their own, and that they do have a reserve of strengths and abilities. So we demonstrate that by allowing people to do as much as possible for themselves, and supporting them to uncover and utilize their unique inner strengths and passions, or their protective factors also. So we can think about how, if trauma results in disempowerment and disconnection, which principles here support empowerment and reconnection? It looks like, to me, pretty similar to some of the symptoms of trauma that we looked at, and how they relate to substance use. Just about all of these principles are based on supporting the empowerment and reconnection of folks with a trauma background. So now let's look at the role of recovery residences with trauma-informed care, or the role of trauma-informed care in recovery residences. I assert that residences are a prime and powerful setting in which to introduce trauma-informed approaches. And the reasons for that are that traumatic memories often resurface, and symptoms can intensify when one is newly sober. I think that probably makes sense to most folks. When you take away what has been effective in numbing or keeping us somewhat separate from realizing the full impact of the trauma, when that is removed, the symptoms, the memories can come back. And often at that point for new residents, they're with you in your recovery residence at around the same time that's occurring. So that's why it's perfect to be implementing some of these trauma-informed principles. Also, we know that disruptions in basic trust, feelings of guilt and shame and stigma, and a desire to avoid reminders of the trauma often put distance between those who have survived trauma and the folks that they previously were close to. This can be friends, family members, informal social connections, but the trauma sort of causes a rupture between someone and their former social connections. So at the same time, however, trauma requires safe and protective attachments with others. So if somebody is possibly not feeling comfortable going to those that they used to trust, that they used to feel comfortable with, because they're feeling ashamed, or they're feeling damaged, or they're feeling triggered by that relationship, what a perfect opportunity to have a recovery residence where someone can find new attachments that are based on safety, trust, and respect and validation. So ideally, I think that recovery residences can serve as stable trauma-informed or trauma-sensitive nests from which those in recovery can start exploring what it feels like to reestablish safety and trust. And during that time, as they're venturing out to explore community and clinical supports, but they're always able to return to the foundational home support of the recovery residents. That's sort of the vision that I have for how trauma-informed care can work in recovery residences. So, and what is that based on? I came across this 3 stages of trauma recovery. It's from the International Society for Traumatic Stress Studies. And it makes very clear that the first stage of trauma recovery that needs to happen before somebody enters into formal specialized clinical treatment for trauma is just the basic establishing safety and supporting connections. That happens in interpersonal informal relationships, and that is the first necessary stage in trauma recovery. So the first step in the first stage is to reestablish that basic sense of safety with others, from which a positive view of the self can then be reformed. After that, after the sense of safety has been established, then it's about relearning trust and control of emotions and impulses, largely through coping skills. That's also done in the context of relationships. At this time, while someone is just working on the first stage tasks, therapy or even just informal conversations directly targeting the trauma should not be attempted. Only after those initial tasks have been completed, when stabilization and reduction in the intensity of symptoms has been achieved, when somebody has coping skills that they found to be effective for themselves, before they enter into formal specialized therapy, which would be the next stage called remembrance and mourning. So, and the risks of getting into someone's trauma, of uncorking their trauma or inviting them to unpack their trauma before then, or by somebody who doesn't have the formal training and experience of working with trauma survivors, the risks are that somebody can decompensate, that somebody's levels of functioning and their skills and their capacities might decline because they're being triggered, because they're having a traumatic recall. It leads to overwhelming emotions, and it can contribute to incidences of relapse if somebody isn't sufficiently stabilized and has a store of coping skills to help them avoid that. So that being said, what a tremendous gift, though, if progress with these initial tasks, the first stage of trauma recovery, can take place within the recovery residence environment. That would mean we are supporting residents to strengthen their sobriety, the basic task of recovery residences, to support residents in their recovery with sobriety, and also help them set the stage or lay the foundation to prepare them to eventually address their unresolved trauma, which is going to be like a feedback loop. Get to the stage where you're able to address the unresolved trauma. That's going to reinforce your recovery from SUD. And recovery from SUD is going to help get you in a better place with the trauma. I'm going to skip this slide in the favor of time. It's just reinforcing a little bit more. But I want to get to the real practical section here. Make sure that we have time to go over these next slides, which are the approaches, tips, and suggestions for fostering trauma-informed recovery residences. It's going to be 4 different sections of these strategies or suggestions. The first one is developing a trauma-informed lens. Then we'll look at establishing physical and emotional safety, suggestions for managing potentially triggering situations, and tips for interacting with agitated and aggressive individuals. So first of all, talking about developing and utilizing a trauma-informed lens. It's really about changing the way that our brain works in seeking to understand somebody with symptoms of trauma. So it's looking at them and their behaviors, and instead of thinking about it in terms of what's wrong with you, we're thinking about it in a more compassionate way. What has happened to you? What have you experienced in your life that's caused the development of these behaviors or these symptoms? It's a much more compassionate way of evaluating someone's behavior, and much less pathologizing. And so when we are using a trauma-informed lens, we're really looking at symptoms as adaptations to the trauma. We recognize that attitudes and behaviors represent an individual's attempt to cope to the best of their present ability with the skills and resources they currently have. So a couple more reasons that using a trauma-informed lens can be very helpful, can really be transformational for the way that you interact and relate with other people, especially those with a trauma background, is that it really reduces shame and stigma around someone's behavior. It also recognizes and emphasizes the role of resilience in human response to stress. A lot of these, as Milena explained, a lot of these symptoms are ways that a person exposed to trauma, their body and mind has developed these behaviors or these symptoms as a way to help them adapt or to protect them from further harm. Also, when we use a trauma-informed lens, it makes it much easier for us as providers or as peers to offer patience and genuine compassion and goodwill towards those whose symptoms can be challenging. Instead of blaming folks for their symptoms, it's bringing some understanding and compassion. And that fact just engenders hope for residents and staff alike, and hopefully makes your job more rewarding. So we can look at some symptomatic behaviors that folks commonly have when they're struggling with PTSD or other stress-related disorders, and think about how these symptoms can be interpreted very differently with and without a trauma-informed lens. I'm gonna just choose a couple here. So the one about not accepting help, that is a common symptom of folks with PTSD, because the origin of it is wanting to regain a sense of, I can take care of myself, I can do what I need to do, I don't need assistance, I am worthy and capable. And the way that can be expressed, it can look like somebody always turns down offers of help or support. Another one, not willing to seek medical services. That can be frustrating or concerning. But if through a trauma-informed lens, we can understand medical settings can be pretty impersonal. It's very top down. We aren't able to exercise a lot of voice or choice. That can take away some of our sense of empowerment. It can also be triggering in terms of the invasiveness of some medical procedures or just simply questions. But instead of just saying, well, somebody's not willing to go get their teeth checked or go for a medical exam as a negative or a pathology, we can think about it in terms of, I understand why that might be difficult for them, or why that might not feel safe. And we can then think about, well, what are some ways that I might be able to support or make that person feel more comfortable or reconsider seeking medical services. And finally, the recurring use of drugs or alcohol is a good example. It's common in the recovery community. If somebody relapses, they slip, we put it on them. We say, well, they weren't ready for sobriety, or they weren't strong enough. They didn't have the will. They hadn't done the work that they needed to do to maintain sobriety. But with a trauma-informed lens, we can understand that somebody was likely struggling with symptoms of trauma, and they reverted to what's worked in the past to help manage their symptoms, which is the use of drugs or alcohol. So if you just think about some of those examples, the two ways of looking at these symptomatic behaviors, you can notice how differently you feel towards someone when you bring a trauma-informed lens to interpret their behaviors, and what the difference is, and how you feel towards that person. Next are some tips and suggestions for establishing safety. This is both physical and emotional safety in the environment of your recovery residence. It's very helpful with folks who are struggling to reestablish or regain a sense of safety in their immediate environment, to speak in a calm, steady, and respectful voice. Also, to provide residents with personal space and to respect their personal boundaries. I'm not going to go through every bullet point here, but everybody's going to be able to get the slides. But also doing things like encouraging residents to express their opinions and preferences, and then validating their feelings and opinions, honoring honesty and appropriate disclosure. All of that goes a long way towards making an environment feel emotionally safe. Also, another suggestion is to use questions such as, what feels comfortable to you, or what feels safe to you, when we're talking to residents and helping them evaluate options or action steps towards their recovery. We're likely to be able to transmit to somebody that we are concerned and want you to be comfortable and feel safe. So please think about that and let us know what would feel comfortable to you. And that goes along with encouraging a resident's voice to have voice and choice in the selection of their treatment and sober support options. And finally, very importantly, to avoid strategies such as shaming, confrontation, intrusive monitoring, and moral inventories as much as possible, to create and foster an environment that feels safe. So there's many situations, many more than we could list on any number of slides, of situations that could be potentially triggering, that could trigger a resurgence or an amplification of symptoms for those struggling with traumatic stress. And those could be situations where a person feels a lack of control, or that they're not in power. It can be situations where there's threats of physical force, interactions with authority figures, arguments, things that sound contentious but in our environment, raised voices, crowded areas, all of that can be triggering. Also, not knowing what to expect, not getting full information, or having there be abrupt changes to plans and schedules can be very discombobulating for folks. As well as Milena mentioned in terms of assessments, being asked lots of intrusive and personal questions, especially when it's not necessary or helpful. So with trauma-informed care, we're aware of different types of situations that have the chance to be triggering for those with traumatic stress, and we look to reduce that or mitigate it. So when a situation is or is likely to be triggering for someone, steps that we can take include helping the resident prepare for what will happen, and help them anticipate what it's going to be like for them to experience this situation and discuss what may help them remain calm or stay collected during that situation. Also acknowledging and normalizing that situations can be triggering really goes a long way to destigmatizing these types of situations and helping people feel like, okay, my difficulty with this situation is somewhat normal. I'm not on my own with this. Other people understand why this can be difficult or challenging. And with agitated and aggressive individuals, strategies that we can take while continuing to foster empowerment and autonomy when folks are agitated or aggressive include staying calm and keeping our voice steady, not raising our voice to match the volume or the intensity of the other individual, but staying calm and noticing that they might take steps down to meet us where we're at because they see we're not going up to meet them. Also maintaining eye contact, keeping appropriate physical distance, being aware of our proxemics and whether we might be meeting their aggression with something that could be interpreted as aggression towards them. Also allowing folks to vent, listening and validating to what their concerns are at this time with a respectful and non-judgmental attitude. And also importantly, focusing on understanding where a person is coming from and focusing on de-escalation rather than winning or losing or proving our point. All of those tips can be helpful. And this is a little diagram that I came across that can be helpful to think about when trying to engage or soothe or just basically manage somebody with a lot of aggression or agitation. First is to determine, is there an actual emergency or crisis or injustice occurring in this moment? Is there a reason to be concerned that there could be danger or something that needs to be responded to? If yes, okay, then we enter into problem solving or resolution mode, which is where we're problem solving mode, right? We're identifying and offering options for addressing the situation, and we're providing clear information and suggestions in a calm tone. If there is no actual emergency crisis or injustice, what we can do is, okay, so let's look at what the individual actually would like to focus on or address at this time. What would be helpful and help them resolve this situation? So help them identify an area for focus and then collaborate on a realistic plan of action. And we don't have as much time as I was hoping for our last part of discussion, but we have a few minutes. If anyone would like to, most importantly, ask any questions or concerns about trauma and also about implementing trauma-informed care at your residence, or just sharing what you think might be a strategy that you learned about today that you think might be helpful with your residents. We'll give you a couple seconds to put it in the chat box.
I actually have one question, Garrett, if you wouldn't mind.
Mm-hmm.
When we're looking at certain behaviors through the lens of trauma-informed, you had that listed, one of them was not bathing. Can you help me understand why a client would not want to bathe as a result of trauma?
Well, this could be discomfort with the body because of violations that have happened. I haven't worked directly, but I have heard of situations with individuals who are simply uncomfortable removing their clothes at all and are more comfortable wearing the same clothes repeatedly day after day and avoid bathing as much as possible. And that could be because of severing of the comfort with the individual body and the vulnerability that can bring.
Yeah, Garrett, I would also add that in a congregate setting where there's other people living there, there's also fear that somebody's going to walk in and that, it's a sense of threat because of, history of sexual assault, for example. That can be common. I've also heard of individuals that want to sleep with the light on, so that they can watch and make sure no one's in their environment. Because the dark is associated with not being able to see, or a violation of safety, or the traumatic event happened in the dark, right? So I think it can be a number of things.
Thank you.
Thanks
very
for
much.
the question. Yes, thanks for the question.
And thank you for the feedback in the chat, everybody, and for your participation today. We appreciate you being here, and please share this with your colleagues.
Yes, I just go ahead and still enter comments into the chat box if you'd like. I'm just going to go through, show you 2 last slides. Brianna will send out the PDF to everyone who registered for the webinar today, and you're very welcome and encouraged to share this information and the slides with your team, with your colleagues. One of the last slides is this section of recommended resources about trauma-informed care, and trauma and SUDs, and it lists books, sort of a section of self-help workbooks, and also several videos that are found on YouTube that are related to these topics that could be useful. And then to wrap up, just want to mention and ask that everyone please complete the post-webinar survey. That's really helpful for us in designing webinars and shaping the content so that it's the most useful and relevant for you all. That's our goal. Also, Brianna will upload the video from this recording to the WAQRR website and to YouTube soon. And if anyone has any questions or wants to be in touch with me or Milena with comments, suggestions, or requests, go ahead and send those to Brianna, and she will share them with us. And I'll now turn it over back to Brianna.
Yes. Yeah, thanks everyone so much for coming. As Garrett said, I'll be sending out the slides and recording in the next few days. And just wanted to let you know of an upcoming webinar that we have this month on August 22nd. We have Introduction to Foundational Community Supports, and you can register for that on waqrr.org/events if you haven't already. So thanks everyone again for coming, and thank you so much, Garrett and Milena, for putting this on for us again. Such good information. So
yes,
thank you.
Thank you all. Thank you all for your presence. Best of luck. Have a great rest of the weekend to you all.
Bye-bye.
Hope to see you soon.